This conference will now be recorded.
Good evening, everyone, and welcome to our active surveillance seminar of this month. We are so excited for this. This is going to be super interactive, and we want you to ask all of your questions. Feel free to post them in the chat whenever you want to, and we will be sure to try to get those in. We obviously cannot offer medical advice, so please keep your questions as general as possible. And I am going to bring up our founder, Rick Davis, to introduce our speaker tonight.
Good evening, everybody. What a great turnout. And I'm really honored tonight. I'm honored and delighted and happy to welcome my friend, Dr. Pamela Munster, who I also want to add has been an amazing support recently for some AnCanners who find themselves living with inherited mutations. And that's really how I found Dr. Munster, because it must have been, well, Pamela will remind me when, it must have been about 5 years ago. I went to see a movie about male breast cancer and men who had inherited the BRCA mutation. And Pamela was moderating the panel that we had afterwards it was in Genentech Hall. And Pamela was moderating the panel after the movie. And I was just super impressed. And this was the first time I really met her. And her job, as well as being a breast cancer medical oncologist, so we talk here about GU medical oncologist, but Pamela's actually, excuse me, a breast cancer medical oncologist, but she also runs the UCSF Center for BRCA Research. And BRCA's a mutation that some of you have heard about, and it increases your risk of for certain cancers, including prostate cancer. And the real key thing, and which appeals to us so much because we are all peer-led here, is that Pamela's a peer because she carries the BRCA mutation, and she's had several procedures, surgical procedures, as a result of carrying the BRCA mutation. She's very sadly lost her dad to pancreatic cancer as a result of the BRCA mutation. Her kids carry the BRCA, or one of them certainly carries the BRCA mutation. So she's really, really a peer. Pamela's been kind enough to serve as a host and a moderator and a panelist on a couple of our webinars to date, and she is now on our advisory board and is involved in some research for the drug that impacts prostate cancer. And she said, could I speak to your guys? I want to hear from your guys. And I said, come on up. And that's why she's here tonight. So I'm turning it over to you, Dr. P.
Thank you. It was like a wonderfully kind introduction. And I know when I come and speak at the prostate forum or so, and people look at my CV and they go like, what does she know about prostate cancer? And I have to say, I learned a lot about prostate cancer, and it's an amazingly different world than the breast cancer world, and also amazingly similar. And I want to walk you through a little bit of like why I'm doing what I'm doing. So I have a mission, and I'm going to share my screen and Rick may not have told you this. I'm a talker and I'm a professor, and I can easily go full professor on you. So just blink when it just becomes really too academic, and I try to make it more simple and easy. But here is, if Alexa, can you just give me the heads up that you see my screen?
We do.
Excellent. And I'm gonna put this on. I'm gonna leave it this. So I'm a medical oncologist. I have a research lab. I run the university's developmental therapeutics program. So I develop new strategies and new drugs for people with cancer. And among a major mission was like, what about early interception or prevention of cancer? And the problem with preventive measures is like, it just takes a lot of patience and it takes a lot of money and time. And so a lot of pharmaceutical companies are actually shying away from something that I think is one of the most important parts of cancer care, is like to actually prevent cancer or intervene early. So here's my talk is often dedicated to someone who's very dear, like a sister to me, who I lost to cancer, and then of course my next generation daughter, who I hope will never have to deal with cancer based on the work we are doing. And so, but here is what I usually start is with a case, and please forgive me, gentlemen. My view is that from the oncologist, and by the end of this evening, I'm hoping that if the view of this oncologist is completely off, that you tell me this, because we sit on the other side. So this is a typical presentation in the BRCA center. Is a 59-year-old man who has a rising PSA. The biopsy shows prostate cancer in 7 of 12 scores. Gleason score is 3+4. No other medical problems, but a very strong family history of cancer. Father died of prostate cancer, brother has prostate cancer, and the younger sister has breast cancer. And this is what I see in the hereditary cancer clinic. And the question always comes up, what can you do that doesn't involve risk-reducing surgery? I do not have to tell this group of men probably, but prostate cancer is the most common cancer almost all over the world now. If you don't smoke, which is all the blues, or some of the yellow ones are liver cancer, and then there's a bit of colon cancer. Prostate cancer will be the most common cancer in men. And while we clearly can prevent lung cancer and probably somewhat liver cancer and oral cancer as in India, we haven't found a good way to decrease the risk for prostate cancer. So our current approaches to cancer screening are somewhat clear. When it comes to breast cancer, mammograms are started at least age 50. Some areas do 40 to 49. High-risk women have more. Colon cancers recently dropped to the age of starting colonoscopies at age 45. Lung cancer is screened for smokers, and cervical cancer is very effective screening with pap smears, HPV testing, and HPV vaccines. But the PSA testing and the digital rectal exam has a little bit been all over the place. I remember when I started my fellowship, men were given PSA tests as Christmas present to then all of us, no one getting PSA screening. And I think this is really an important, we need to get a better handle on who should be screened and when and with what. So again, what is the treatment option? What are the treatment options for localized prostate cancer? The indolent low-risk disease is active surveillance. And that can include anything from biopsies, PSA tests, digital rectal exams, MRIs, but it's really no treatment to removing the prostate or radiation, which is at the other spectrum of treatment. And here's where it gets a little complicated, and I'm gonna slow this down and I'm gonna show you. So the data looking at 2,600 men who were eligible to be randomized to either surgery, meaning removing the prostate, having radiotherapy, or having active surveillance, 1,600 of these 2,600 men decided to be randomized. And then they got randomly assigned to either get a prostatectomy, radiotherapy, or active monitoring. And the really incredible data is that in terms of prostate cancer specific survival at 10 years, almost no one died of prostate cancer, and it didn't make a difference what you had. When it comes that, but did you have metastatic prostate cancer? Did the prostate cancer progress? you can see here the green line, which is the active monitoring. There is more men who will have a diagnosis of metastatic prostate cancer. So what this shows, this is the bar for 10 years, and this is the patients without disease progression. So 100% would mean no one has disease progression. And here, like about 20% of men who have had prostate, well-developed metastatic prostate cancer during the 10 years of active surveillance. That still does not translate in prostate cancer deaths. So this is really good and reassuring data that active surveillance is really justifiable. So then, what are the challenges with active surveillance? If you look here, if you look at the number of patients who ultimately underwent a radical intervention, meaning either radiation to the prostate or surgery. Of course, these in the surgery or radiation group, they got the treatment immediately because they were randomized to that treatment. But those who had active surveillance or active monitoring, there's a fair number of men in 10 years, almost 50% in 10 years, actually convert into a more active treatment. Now, that being said, though, is like I still feel like having had risk-reducing surgery for a BRCA mutation, having your surgeries pushed back by 10 years is probably still worthwhile doing it. But the reality is still a lot of men are crossing over. And why am I showing you this will be relevant in just a little bit. So when they looked at the patient-reported outcomes and compared either monitoring, surgery, or radiotherapy for prostate cancer, and they looked at the overall physical health score, the three interventions were essentially the same. Everyone had some effects on physical health score, but if you look at the beginning to the end, there was actually much change. So even those who ultimately ended up with a prostatectomy or radiation physically felt quite well. Same is true for mental health. Same is surprisingly true for anxiety. They didn't find much difference in terms of anxiety for those who have active surveillance versus those who had an intervention. And this is one of the questions I would like to ask you, like how much anxiety is associated with active surveillance, or do we as medical team, can our data and our reassurance provide enough for men not to feel too anxious? And similar as depression, the depression score was actually quite low and there wasn't much difference. This is less so for EPIC items, including erections, problem with erectile dysfunction, sexual function score, and sexual bother score. Clearly, those with active surveillance or active monitoring in blue did better. They have better firmness and definitely less erectile dysfunction. So in terms of while overall, men did very well with surgery and radiation therapy, when it comes to sexual function, someone on active surveillance does better, but you see the difference are still not enormous, but there's clearly better sexual quality of life on active surveillance. So then the Swedish or Scandinavian group did a study and they followed men who opted for active surveillance. They followed them for 27 years. They followed them for a long time. And what do we see here? That in terms of death from any cause, the patients who had a radical prostatectomy did do better than those who had watchful waiting. And that was also true for deaths from prostate cancer. So surprisingly, there was a higher chance to die from any cause and a higher chance for dying from prostate cancer in the watchful waiting. So who are the men who are more at risk? If you were diagnosed with prostate cancer after the age of 65 and did active surveillance, there's actually no difference in terms of outcomes. And if you look at these curves are very, very similar. Watchful waiting is similar to radical prostatectomy in men over 65. And that's true for either dying from prostate cancer or dying from any reason. This is very different in men who were diagnosed younger than 65. And I think this is where Rick alluded to, is like the risk of associated with a hereditary prostate cancer or hereditary mutation, because we think there's something different if men who were diagnosed with a younger age prostate cancer. And you see there's clearly a difference here. So makes a difference whether someone has been diagnosed at what age. And then similarly, this is the same as similarly when you have low risk prostate cancer. In blue here, the risk of dying from prostate cancer when you have low risk at 18 years is actually less than 10%. So this is, and that is very low whether you have a prostatectomy in this area or you have a watchful waiting. That is if you have a higher risk group or intermediate group prostate cancer, the risk of dying from prostate cancer is higher in the watchful waiting group. But still, if you look at this at 10 years, the risk of having a prostate cancer related death at 10 years is 10%, versus in the prostatectomy is about 5%. Still low, but still suggesting that there are men out there who probably need an intervention, and we need to find out who are the men who need that intervention. So what is it that, and as I said, my mission, and in part of my mission is in part completely guided by the needs of my family, my patients, and knowing that I have a son who has a BRCA2 mutation is associated with a family-related risk is clearly something that this disease has very personal implications for me. So what could we do to create new options as an alternative to risk-reducing surgeries? And for someone who is like, as Rick said, a peer who has lost many organs in order to prevent myself from having breast and ovarian cancer, I would like to see the same for men as well as alternatives to risk-reducing surgeries. So what could we do? Can we do localized drug, anti-cancer drug delivery to the organ only? What would that mean? So we have opportunities that would reduce our risk for progression, meaning going from a low-risk prostate cancer to something that's more high risk and then progresses. The benefits would have to come from treating the organ only. Localized anti-cancer drug delivery only works if it stays in the prostate and the tumor stays in the prostate. Localized drug delivery would lend itself probably most ideal to an organ that is actually really important for people to keep and difficult to remove. If in breast cancer, if you could remove just the tumor with minimal surgery, with a very short procedure where you can remove the tumor with a small scar and not a lot of side effects, and that may be better than localized drug treatment. So what were we looking at? So the first implant we developed was for breast cancer. So when I was playing around in the lab, we developed this silicone-based implant that looks like this, and that is sitting in front of the muscle behind the breast tissue, and that delivers an anti-cancer drug to the breast. Now, this implant is ready to go, but the development path for breast cancer and the prevention is actually not trivial. So in looking at this, then we started testing this in large animals, and mainly actually we test our implant in goats or sheep, and the device is now ready. But then I had a very interesting conversation with Dr. Peter Carroll, who you all know, And he said, why are you playing around with breast cancer? Why aren't you doing this for prostate cancer? Our surgery is much more difficult. Prostate cancer has good drugs, and it would be very easy to put an implant in prostate cancer. So we had a major shift to prostate cancer. So then where do we think we can make a difference? Where do we think we can may offer something? And we think if we did localized drug delivery in someone who is not quite the right person for active surveillance, but really not quite the right person to remove the prostate or do radiation therapy, this is where we could come in and treat the prostate just with localized drug delivery. So how would this work? So what we came up with, we use this basic small silicone-based implant that fits into a biopsy needle. Most of you probably had a biopsy at some point. You know, the needle is actually quite small. So we engineered our implant that has a drug in it, anti-cancer drug in, to get through this biopsy needle and be introduced through a Trans-Perennial Approach. And I heard Howard talk about having a questionnaire on like a Transperennial Approach versus Transrectal. And I like to talk about this just for a minute, because a Transperennial Approach is for an implant is probably a much safer way to implant this implant, because it doesn't go through a less sterile. We can sterilize the perineum, we can't really sterilize the rectum as easily. So what was our goal in making this implant? So we want to have localized drug just in the prostate. We want to have drug for at least 2 years. We want to do this in a very easy procedure, very similar to a prostate biopsy. And we want to use materials that we know we can leave there without having any safety signal. So we came up with silicone, because we know silicone has been around for many stents, for implants for a long time. So then what drugs do we have to play with? And like I know this may be a bit overwhelming, but these are the drugs that are currently approved for the treatment of prostate cancer. However, almost all of these drugs are really approved for metastatic prostate cancer. The drugs that are approved for early prostate cancer is bicalutamide, also known as Casodex. And those of you who have been on ADT, androgen deprivation therapy, they're probably familiar with the term Lupron, which is a way of shutting down the testosterone production in the testes, in addition to bicalutamide, which is in pill form. This is the LHRH agonist. It's a shot given either monthly or every 3 months. Recently, there's also been an oral form, so this may actually change, and then bicalutamide is a drug that's given every day. All of these drugs are of great interest to me and my team, because we could play with them. But the implant that we started with is bicalutamide. So the first step, and this is what this is the centimeters. This is what our implant looks like. is very, very tiny, and I walk you a little bit through like how we did these studies to walk you through what data we would need to have in order to have an idea that this may work. So we wanted to make sure that we have an implant that delivers drug. We not only want the drug to come out, but we want it to come out for at least 2 years. So what we did, and Nella, who is depicted here, my postdoc, spent 30 months measuring how much drug comes out every other day. Literally for 30 months, every 2 days, she measured how much drug comes out of an implant that was sitting in tissue culture. So we know that after 2 weeks with an initial burst, we know that drug comes out consistently for 30 months. We also wanted to know, does it work against cancer cells? And what we see here is like, well, we looked at if you gave a cancer cell testosterone, you get a big spike in PSA. So if you gave cancer cells testosterone, you get a big spike, and we measured this by PSA measurement. If you give bicalutamide, the drug which is Casodex, that spike should go away. And as you see here in blue, This is when if it's given like orally versus locally, you see that spike doesn't happen anymore. So we know that we can get drug out for at least 30 months, and we know the drug that comes out is active. And then before we started putting this into patient, we actually did this in a canine prostate, and we put 2 implants in, and then you see here, this is what the implants look like in a 3 centimeter. This prostate is just over an inch, and male prostate is probably a bit bigger, and this is what the implants look like. They're actually quite tiny in the prostate. So the reason why we have these cuts here, because we measure drug levels around this. This is not what typically happens in the prostate, but this is a slice of a prostate, and this is a prostate coming out of those dogs, and this is the bladder, urethra. And what we found, what was really important for us to know, so in red, these are the level for the prostate. So we know that drug levels are actually quite similar if you use an implant into the prostate versus if you gave the pills. But what's really, really different, that drug levels are really high in the blood and really high in the brain, in the cerebellum, and in the liver. And we have no drug levels when we give this via implant. So really, if you put an implant, or like right now we do 8 to 16 into the prostate, the drug really stays in the prostate only. It doesn't go anywhere. If you take Casodex orally, you see what's actually really interesting. There's actually a lot more drug in the brain or in the liver than is in the prostate. And not surprising why men who are on Casodex or hormonal therapy feel kind of like a bit more tired, and there's that idea of some brain fog that's been noticed. And I think having seen this, how high the drug levels are in the brain with these drugs is not surprising. So going back to our implant, this is how we started the first trial in New Zealand and Australia by introducing this tiny implant. This is a feasibility study that we looked at this implant in men who were already scheduled to have a radical prostatectomy. And I have to say, it's always amazing to me how men and women donate their time and bodies for research. This is the man who is having a plan for prostatectomy and then actually has agreed to go and have this implant in, so we can measure whether this shrinks their tumor, delivers drug, and what happens to LUTS system, the lower urinary tract system. The implant stays in for 6 to 12 weeks, after which it comes out by surgery. So we have currently 4 sites in Australia and New Zealand, and the first patient was enrolled in October 2020, and we have so far enrolled 7 patients, and the slow enrollment is predominantly because New Zealand and Australia shut down for research for the better of a year and a half at COVID. And as you can imagine, it's been not very easy to manage this trial all on Zoom in New Zealand and Australia by not having any access to the country. So then we did this in patients, as you can see, and this is the MRI of a prostate. And if you look at this, this is the prostate. This is the peripheral zone for those who really on top of the anatomy of the prostate. And this part is the tumor. And we put these implants in, and you can see here, we have actually really high drug levels right where this implant is. We have drug levels through the rest of the prostate, but the highest drug levels are right around where the implants are. So very encouraging data. Then we decided with the NCI here in the US, we wanted to do a study for men who have need radiation and need systemic androgen deprivation therapy, those men who get Lupron or bicalutamide, and many men who actually would be candidates for that will opt out because of the side effects. Also because sometimes it's medically contraindicated to give Lupron and Casodex. The NCI radiation therapists, they were very excited about the prospect of having radiation with an implant that delivers a hormonal therapy. So what they do is like we do the implant, we then do spacer, radiation planning, they get radiation therapy, and then we follow the tumor and the PSA along over time. So far, we have treated 2 patients. We are currently redefining our implant, and we are currently looking for more patients. So the next patient probably going to go on April or May. So 2 studies that are currently ongoing. One is open in New Zealand and Australia. That's currently also now this trial is also opening at the NCI for the pre-prostatectomy. And then we have the radiation therapy studies. Both of these trials are open. And then hopefully at some point we'll do a pilot phase for Biolin randomizing patients against active surveillance. And this is about, this will be a randomized trial where we randomize against 2-to-1 against active surveillance. So what else is on the horizon for me? So this is now in the hands of a very capable company. They're doing this. We're gonna move forward in terms of further development in the lab and with Alessa. And what I'm interested in looking at other anti-androgens, more newer anti-androgens, maybe more potent anti-androgens, implants with PARP inhibitors for BRCA and ATM mutation carriers. For those with the PARP inhibitors are very specific drugs for patients who have BRCA mutations or ATM mutations or hereditary, have hereditary cancers. And if I may take you back just quickly in terms of for men with localized prostate cancer, about 8% of patients with prostate cancer have mutations. And of those 8%, the majority are ATM or BRCA2 mutation. So we're looking for specific drugs for those patients. And again, these are the 8% of the entire group. Among those 8%, half have ATM and the other one have BRCA2. And so I think with this, we're also looking at, of course, the breast implant, and then I'm very interested in benign prostate hyperplasia. And with this, the prostate has entered my professional life quite significantly. I'm Rick, I'm no longer a breast cancer doc. I'm now looking like I'm doing a lot more in the prostate world. And this is my team, my lab team at UCSF, and then my Alessa team with the company. And I would like to not ever forget to dedicate my work to my father, who fought a very hard battle with BRCA-related pancreatic cancer. With this, I'm like to revert back and be happy to take any questions. And I think I'm off the slides, yeah? Alexa, am I off sharing my screen?
Yes, you are.
You're okay.
So, Pamela, thanks for sharing your personal story as well as your, I don't know if we would call it progression or advance into prostate cancer. And we're happy to, I know that you're very interested, as Rick said, in knowing more about guys like us. But you brought up something about anxiety, and that seemed to trigger some reaction from the men here. But I wanted to mention that almost a year ago, we did a survey. 165 men responded from the AnCan and the ASPE group. And one of the things that we found was about 30% of the men complained or mentioned that they had anxious surveillance or anxiety issues at places where you would expect that to happen. Waiting for the doctor's office, waiting for a test result, waiting to undergo an MRI or a biopsy. And this would get them upset. I should note that about half of them had pre-existing anxiety prostate cancer just added to it. And, you know, why is any of this important? Well, as you noted, a significant percentage of the men, I can say in this virtual room, significant percentage within 5 years, 6 years, or 10 years will convert to active treatment from active surveillance. And anxiety plays some role, and it's not just the patient, but it's also the family, the spouse, the children, and even the doctor are sources of anxiety. So I wanted to share that with you, and I think Alexa can cite some of the reaction, and others should respond as well.
Yeah, so I think, Dr. Munster, what you talked about really resonated with a lot of our attendees tonight, because anxiety is something that comes up in all of our groups with AnCan. It's not even disease specific. And I was so appreciative of people offering their viewpoints in the chat and I liked one of the suggestions of, if you're not sure if you have anxiety, maybe you need to take a general anxiety disorder test. Do you have any perspective on that, on how to gauge maybe an active surveillance patient's anxiety levels?
Yeah, in the hereditary cancer clinic, anxiety is just one of the most foremost important discussion, because if you know that you have a mutation that predisposes you to cancer risk, that creates a lot of anxiety. So we actually talk a lot about anxiety and how to mitigate this, and I think thank you for bringing up the pressure that family members can bring on someone who's quite okay with tolerating risk. Like if you decide for yourself that a 10% risk of having a prostate cancer at 10 years when you're 75 years old is acceptable, that you don't want to go through a prostatectomy, I have seen the wives pushing a little bit harder, and I think it's important to not let your anxiety guide your medical treatment. And I think we learned a little bit over these 2 years of COVID crisis that we actually have a very poor handle and how to address risks and anxiety, and how as a medical community we do a really not a great job in managing the difference between someone being anxious and fearful of dying from cancer and offering an intervention really doesn't really change that risk. And I think we just have to be clear. I think what's really important in my book in prostate cancer is to find out who is at high risk to progress and have disease, and not just offer prostatectomy for everybody.
Now, Pamela, and we do have your permission to call you Pamela.
Yeah, put this in an email.
You mentioned just somebody was asking for some clarification. We know you did some research in Australia and New Zealand, and just want to see if you're doing some trials or you're about to do some trials in the US, and also what role does active surveillance play in these trials? In other words, most people on active surveillance in their minds they don't think about it that they're actually going through a medical process with all the biopsies and the MRIs. All they know is they're not having surgery or radiation right away. So thing is I think you're planning to bring this approach to men on active surveillance, but will it stop being active surveillance because it's switched over to a medication? Does it mean anything? Is this a philosophical question, or any rate?
Howard, that's a very thoughtful comment. I actually have not thought about this in that prospect. So the first question is easy. Are we going to bring these trials to the US? They are in the US. The NCI has both trials open. So you can go on IVID trial. What we don't have is right now, the trials that are open are for men who have planned to do a prostatectomy and for men who have radiation therapy, because we don't have enough data yet to say this really works, that we can tell someone they can stop active surveillance and do this. Now, active surveillance is a bit of a mixed bag, if you will, right? Is you don't have any treatment, but you have a lot of procedures. You have MRIs, PSAs, biopsies. So if we did this implant in you and we deliver Casodex to your prostate, we actually have an intervention. We just haven't removed your organ. So does active surveillance stop? No, it actually doesn't, because we still want to make sure that the prostate cancer doesn't get worse. But then if you do a prostatectomy, surveillance doesn't really stop either.
Now, let's see. I think I mentioned to you that we had Dr. Schweitzer, not Albert Schweitzer, the other one from Washington State, talked to us, and I think it was on apalutamide, if I said that right. And he was starting to try this medicine on men who technically were on active surveillance. Is that sort of your plan too? I mean, you are going to try to look at men on active surveillance.
Yeah, the difference though is that we don't want to give people something systemic. Because if you get hormonal therapy systemically to prevent prostate cancer, you have to deal with all the side effects. And I think the data we have in comparing the plasma levels, the blood levels, and the tissue levels, as in the brain and lungs and everything, from oral apalutamide, I mean, we use the biclutamide, and an implant biclutamide is vastly different. So what we're hoping is, by localized approaches, the drug only goes to the prostate and nowhere else.
You know, just to follow up, and then maybe I'll switch it over to Alex if she's ready. A good question from Ron. You know, can you clarify what the side effects are with your approach?
So far, in the 9 patients we have treated, we've seen no side effects, so of course the side effects are introducing this implant. It requires the equivalent of what you have with a biopsy. It's like the same needle. So the implant is the size of a biopsy core. We basically putting in what we would take out with the biopsy. So you have local irritation. That's what we've seen. One man had some post-operative voiding problem for 24 hours, but that's the side effects we have seen. Because we don't have any drug levels in.
So we got a really interesting question. Could this be used with other treatments, or is it just being studied alone?
Well, right now we are in infancy of doing clinical trials. It's like, but yeah, they could be studied with other modalities, right? So we can give, if we feel strongly we need to give more drug to the prostate, and we still want to give Casodex by pill, and we still want to radiate, people can do this. If you want to do this to shrink the tumor in the prostate so someone can have a better surgery, that can be done. So this is not meant as one modality. So.
And then Howard actually asked a very interesting question. What are the similarities and differences between prostate cancer and breast cancer? What is active surveillance like in low risk breast cancer?
So that's a much more challenging question in my opinion. And if you active surveillance in a low-grade breast cancer mean you have a breast lesions that's 1 or 2 centimeters or less than an inch, that's sitting in an organ that you could easily get to and cut out. And that's really a minimal surgery. So I'm really struggling with the concept of having a cancer left behind that you could easily remove, right? Removing a cancer from the prostate is really very, very different because the prostate is, whoever designed men has not paid good attention to plumbing. This is not a good spot for the prostate to be. So I think, and I think that makes everything quite difficult. Like the surgery is more difficult, getting to it is more difficult, radiation with breast cancer is a lot easier. So I'm struggling a little bit more with the concept of active surveillance in breast cancer.
Well, you know, for men who are undergoing or facing this surgery, it's well, you know, kind of to shift into some of the questions that you want us to answer. I mean, so what's at stake? You know, if with, you know, we don't talk that much about it here, but sex is, you know, part of what's the situation is. In other words, you know, is it worth it, you know, allegedly for peace of mind, even though you have low risk prostate cancer, is it worth it to have surgery or radiation and you know, potentially face all kinds of issues, you know, sexual issues, on the one hand, and well, let me think about this too for women. I mean, the breast is a sexual organ as well, but I guess maybe that's another difference. And I can't speak for women here, but you know, if women have the surgery, it maybe poses less of a challenge to the women than the men undergoing prostate surgery or even radiation. So I'm trying to tease out.
So I think that's, but see, if you do breast surgery, unlike prostate surgery, we only take out the tumor. In any low risk breast cancer in a woman over 70 actually doesn't even need radiation therapy. So, and we don't touch the nipple stays, and it's a 1 to 2 centimeter under an inch scar. So at the side of the breast, that's very different than taking the entire gland out or radiating it. And the other problem is and I wasn't trying to make a bad joke about the plumbing being in a bad spot. There's all these nerves going through that. So there's a big bundle of nerves that go right through that spot. When you radiate this, or when you do this with surgery, you disturb a lot of these nerves, and that's what causes some of the sexual side effects. In breast cancer, you don't actually have that. This is different than saying a mastectomy, which removes all the breast tissue. A lumpectomy just removes the tumor. And low-risk breast cancers, anything that's more than 2 centimeters, is just not low-risk breast cancer. Unlike in prostate cancer, the survival of people with breast cancer is much more affected. So I think that's why we struggle a little bit more. That's why we struggle a little bit more about the active surveillance in breast cancer.
Yeah, Pamela,
you saw that data of 1,500 patients, right? 500 in each arm at 10 years. The survival was different. There was no difference whether you did active surveillance or prostatectomy. Why would you want to take your prostate out?
Yeah, exactly. Yeah. But some men still want it out. So now you had sent a bunch of questions, Pamela, that you wanted to know about. I don't know what the best way to facilitate that is. If we should, you know, just bring up the questions and let the audience respond.
Yeah, I mean, and one of the main questions for you is like, how do you deal with the considerable medical pressure on anxiety that you have prostate cancer and now you're not doing anything actively? But it's this, you're actively making sure it's not growing, but you're not actively treating it. How do men treat with the anxiety, and who causes the anxiety? And I think you in part already addressed that. Who causes the anxieties? Does it come from the men? Does it come from the family? Does it come from the doctor? And
yes, yes, and yes.
And then the question is, what can the medical community do? And is the data clear that you don't have to have a prostatectomy, because the data with active surveillance is actually really good, except for men with high risk features. So how is medical information communicated?
Well, you know, if anybody wants to respond in the chat, feel free. I don't know, Jim, maybe you want to dive in on some of that, just to catch you off guard.
Yeah, you really did catch me off guard. I don't know. I'd rather at this point just see how the discussion evolves.
But you did have a question in there somewhere.
I did have a question about the implants, and my question is, are they intended to be curative, and are they an alternative to active surveillance? Are they an alternative to radical treatment, or both? I'm struggling a little bit with where all this fits in.
Okay, great question. In someone who, instead of opting out of active surveillance to go to a prostatectomy, we're hoping that we could give an implant that would reduce the rise in PSA, or increase in Gleason score, or increase in tumor size. So it's sort of like something in between. We would also see a role in terms of in those who have radiation therapy because they have higher risk prostate cancer and now need systemic hormonal therapy, that we could forego the systemic hormonal therapy and just treat the prostate and radiate. So to boost the efficacy of radiation therapy.
And then we actually have an interesting question. And what you've researched about this, do you see any precaution maybe need to be taken, like with exercise, physical activities, or does that have any effect?
So we were actually really, that was an important question we had to answer, like, are these implants moving around? You know, what is what's the likelihood that you could break them, they could rupture, they could fall out. So we put these implants into a bunch of very rowdy, highly active hounds, like big 20, 50-pound dogs who basically just run around the whole day. And nothing happened to the implant. They didn't feel anything. There's no bleeding, no things. They didn't move around. Just like, they really stay put. They don't come out, and as the drug, so 60 or 70% of these implants are simple drug. Once the drug is exhausted, the implant is essentially down to a very, very fine sliver of silicone that stays in.
Now, Pamela, you asked, let's see.
Howard, can I come in just for a quick second?
Of
I
course.
have an idea that may work, We've never done this before, but we can try. Most all of you have been very good and turned off your video, except Mason. What a surprise. And one other gentleman who I don't recognize. But let's ask this anxiety question again. And anybody who wants to answer should turn on their video. And then we'll call on the videos that are turned on. And let's see if that works. So if you would like to give any feedback to Pamela on anxiety, please turn on your video and we'll call on you. Anyone?
I'll say something because I can't help myself.
You will, but hold on, we've got somebody. So
Okay.
you'll have to sit. We got two people who want to say that. I mean, three. Hugh wants to say something, and I'm putting it back to you to handle this, and then we can change the question, and everybody will turn off their video, and we'll try it again. So go ahead, Alexa. See if we can manage this for Pamela.
Sure. So, Ian, I'm calling on you
Yeah.
first.
Oh,
Go
okay,
ahead.
thanks. I just wanted to address the anxiety question. So I was at Gleason 6, active surveillance over 2 years, almost no anxiety whatsoever, very comfortable with it. Now I'm at Gleason 7, and I'm looking into different treatments. And it's so daunting because everyone has an opinion and everyone is so biased that now I'm anxious because I don't want to get it wrong. And then every day there seems to be new treatments coming out, and I can't wait to find out how those develop. So I'm in this kind of rock and a hard place sort of thing, trying to decide what's best for me.
Thank you.
Thank you.
Who's next?
Thank
Who's
you.
next, Alexa? Thank you, Ian.
Michael,
Okay, thanks. I guess I put 10 comments in the chat. I sort of have had the reverse experience that Ian just described. I was first diagnosed at 3+4 and was extremely anxious about what I was going to do in the way of treatment. A second opinion on my biopsy downgraded me to a 3+3. So I was very relieved that AS suddenly became a viable option for me. And I have still done a lot of research on treatments and talked to a lot of surgeons and radiation oncologists, and have decided I'm very comfortable with AS, and at least until I get my next round of tests, which should be next month. So I think about the cancer every day, and I am anxious about it to some degree, but it doesn't keep me awake at night. Otherwise.
thank you
And
so much.
turn your videos off when you're done talking, otherwise the system won't work. Thank you.
Thank you so
Go ahead,
much.
Alexa.
And then Ira.
Hi, and I was diagnosed in 2009 when active surveillance really wasn't, used very much. Fortunately, about a year later, I was in a research program at UCLA where they did the MRI guided biopsies. But anyway, at first, when I was diagnosed, I felt, stress, and I had all those negative feelings, thinking the cancer's going to go all over the place. But with education, things like that, I simply right now it's just a non-entity for me, and I like Howard and Joe and all those people. I'm active in a different support group where I facilitate, a group. So I changed, I guess, lemons into lemonade.
Thank you so much. Hugh, you're on.
So I didn't really think that I was getting anxious on things until guys like Howard and the support group helped to realize that I do get anxious. And what I noticed is I get it, kind of coming up to different appointments. So the PSA, as I get up to the PSA, then all of a sudden I find the couple of days beforehand, I start going, oh, maybe I haven't done enough on the nutrition. Maybe I haven't worked out enough. Maybe I should have done more work on supplements. And then I get a PSA, and the PSA is okay, and I go down and I feel like I'm okay. And another big help for the support for anxiety is support groups. So I assume that, like on the women's side, you have support groups for women also.
Yeah.
And I don't think there's nothing that helps you with anxiety than listening to a bunch of other guys who are going through the same thing.
And I should just add, by the way, Pamela, because I don't know if Howard mentioned to you, but Laura Esserman reached out to Howard because he's the active surveillance guru for us, and he's sitting on a committee that she's holding for active surveillance in breast cancer. So,
Hey, thanks for the plug, Rick.
yeah, no. Pamela, what? If we don't have anyone else who wants to talk about anxiety,
We
last time.
do. We have Mason.
Well, I was first.
Okay, you two guys go first. Go on.
I've been waiting patiently.
Okay, Howard, go on.
Yeah. Anxiety. I've been on active surveillance for 12 years. I think I might have had 2 days of anxiety, and it was from pressure from a community urologist who set a deadline on me and said, bad news, you have cancer. Good news, I can cure it in my operating room next Tuesday. And so the thing is I had done my homework already. It's 2010. So like Ira, it was early in the game for active surveillance. And I had actually arranged a second opinion the next day at the University of Chicago. And the doctor there says, you only have one core and it's very low risk. And he politely said, well, surgery might help you, but you don't need it. And he says, I predict 10 years from now, you're going to be the same as you are today. He said, you're the poster child for active surveillance. And then he handed me a pile of studies from Dr. Klotz in Canada, and I never looked back. And so, but that's my story, turn it over to Ken.
Thank you, Howard.
Thanks, Howard. If I may, just an observation that a number of the men who have shared brought to mind that there is a learning curve that helps many of us deal with anxiety and the depression. I think another thing, and I'm not sure of the wording of this and if I'm going to say it correctly, but I've seen many men who try to man up to prostate cancer, and it is not an easy thing to do. That's why I seem to have found that men who avail themselves of support groups like this, and I've been, gosh, Rick, how many years have I been coming and telling you terrible, terrible jokes? Oh, I remember, because Howard said he's 12 years on active surveillance, and I'm actually the poster child because I'm coming in at 11 years. So there you go, Howard. But it is because of people like Alexa, Howard, and Rick that my anxiety level is low down. I would be lying if I said I never suffer from anxiety, and I do, because treatment results still come with a question mark. And most men that I know hate question marks, especially about their health.
Mason, you're leaving out a very, very important aspect of you yourself, which will be interesting to Pamela, which is not only do you have low-grade active surveillance prostate cancer, you also have low-grade active surveillance kidney cancer and low-grade active surveillance bladder cancer. So
Rick, you've got the biggest mouth in 17 counties, and I don't care what your accent sounds like. I don't like it. And Pamela or Dr. Munster, I beg your pardon, I do have a bad sense of humor.
I do, or you do?
We know that Mason does, but I mean, I do think
Rick get into it often.
I think that Mason knows I love him, and I think it really is it's always amazed me that he's in there doing his active surveillance, but he's got 2 other cancers that he's got to worry about at the same time. And I think it's remarkable to be able to manage all of that under active surveillance. He's an unusual character, but we all know that. Now I've got another. You've all got your screens off, so I've got another question that I know Pamela alluded to, and she's interested. How many guys here are willing to discuss this? How many guys here have had pressure by their wives put on them to get off active surveillance? Anybody want to put their camera on for
And
that one?
just put your camera on. We can take a quick poll that way, or you can post it in the chat.
Or you're willing to say something. Okay, we got a couple of guys. Would you be willing to speak on this?
If you would,
Let's
just raise
try.
your hand and I can call on you.
Looks like Dan is trying to get in. Dan, are you trying to respond?
I'm here now.
Go ahead.
Yeah, when I first was started active surveillance, my wife was, kind of seeing it was kind of a hassle, and she commented, well, why don't you just have it taken out, but because of all the groups that all the information that I gained from the support groups, I feel comfortable being on active surveillance, and she's come to accept that maybe it's okay. If it's okay with me, then it's going to be okay with her. But yeah, she wanted me to do something about it initially.
Thank you for sharing that, Dan.
You're welcome.
Don, do you want to share?
Sure. I think it stems in my case from my better half is exceptionally bright, but she's not, hasn't been versed. It has to do, I think, with anybody mentioning the C word. And if you have cancer, you should have it out. I don't know of anyone, as Dr. Munster said, that's had breast cancer that goes on active surveillance. So from the female perspective, and that being an arena where they've utilized similar tactics, well, let's just have a mastectomy. Well, let's just do a prostatectomy. It's a very treacherous path when you think about any of the potential treatments if you are either on the edge or past the potential for active surveillance. I would consider myself as an accidental active surveillance guy or a watchful wait. I'm in the process of trying to get a PSMA, which will allow me to make a better determination which way to go. I think over time, and it has taken some time to move through that education process for both of us. I see it time and again and hear it again in the groups. Just get it out. That's the approach. And it's fearful, just that all of the fear that surrounds cancer of any kind. I fortunately have been not too worried or not really anxious. So thanks.
Thank you, Don. And one of the things that I loved is that you still started that off with a compliment. So don't think I didn't notice that. So thank you, Don. I appreciate you sharing. And then Michael, did you want to share?
I'm never right. I'm never right. So I can also say that.
Go ahead.
So I think there's an important distinction to make. Is like, when we talk about breast cancer, there's a lumpectomy, which just removes the tumor, and then there's a mastectomy, which removes the breast. In prostate cancer, you don't actually have that option. You take the whole gland out, and I think that's very different. So when people say just take it all out and you take the whole organ out, that's not the same proposition than just cutting a small piece of tumor out. And as I said, in breast cancer, we don't want to do mastectomies ever. We don't want to take the whole breast off at all. There's actually medically rarely a reason to take the whole breast off. We just want to take the tumor out if you have to.
Yeah, Dr. Munster, you don't count focal therapy? which is
You know,
partial.
I do, but that's when I understand when people talk about just take it out, they mean most people don't have just a tumor taken out. It's like so I think the problem is take it all out is that it refers to, it was my understanding, but I'm here to learn that this is a prostatectomy.
Yeah,
And then Michael, did you have something you wanted to add?
Oh, well, yeah, just on the question of whether my wife has had any.
Sure.
Not my choice. My wife had breast cancer about 3 years ago. And even though it was a very small tumor when they found it, her reaction was just get it out and had a mastectomy. So that was her initial reaction when we found out that I had prostate cancer. But she's a smart lady. She figured once she learned more about what the treatments entailed and what the consequences of the surgery would be, and or radiation for that matter, and she, like me, was very interested in knowing what alternatives were out there. And so that's, as it turned out, we had some good luck that brought me even more forcefully back to AS, and that's where I am today. So yeah, there's no pressure on her part for me to do more than that at this point.
Joe brought up a good idea of sort of a straw poll of how many attendees would consider Dr. Munster's approach. Do you think, Alexa, do you think you can facilitate that?
Sure. So we're kind of curious how many people, after listening to Pamela's presentation, might consider that as an option, something they might either like to pursue, or if it was offered, they'd be interested in it. So if you could say in the chat, maybe yes or no, or turn on your cameras and yes, we would be really interested to hear.
On your cameras, guys, if you're interested, if you would consider this local drug therapy as opposed to radiation or surgery or focal therapy, turn on your cameras as a yes.
And then if you do have a comment, you can let us know in the chat, and then we'll call on you if you want to speak.
Right. Sorry that we have to do it in this rather difficult fashion, but we're not on a webinar platform, and so it's hard for us to do it. But you guys are doing great. So anyone else? So how many do we have here? We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10,
11 on camera, and then we have more in the chat.
And we have more in the chat. And so keep an eye on the chat. We have 51
and
people.
Gary has a comment about this. So Gary, take it away.
Unmute, Gary.
Turn on your mic. Turn on your mic.
Okay, sorry about that.
And you went the wrong way again. There you go.
Am I unmuted now?
No.
Good, go. Don't touch it. Leave it alone.
Okay. The comment that you made about after the implants had no side effects on the other parts of the body that you looked at, the one chart that you had when someone is taking like Lupron or, one of those types of medications, and all the side effects that are associated with fatigue, gaining weight, hot flashes, cold flashes. It seems to me, I don't know how you came upon it, but what a novel idea of putting medicine only in the spot that it's needed and doing the research to find that that medicine stays there and works with such effectiveness. I have the onset of glaucoma, and there's a little capsule of medicine in my eye. I can't think what the name of it is right now, but it stops me from taking drops, because what it does is puts the medicine right in my eye without me having to deal with the drops. This almost sounds like the same type of approach. I am an active surveillance guy for almost 12 years now. And luckily enough, my disease is in the same place it was as when I started, which is a Gleason 6. I do suffer from anxiety from time to time about the PSA test and what would I do? Plan B. I haven't really, everybody should have a plan B. I don't really have a plan B because as time is going on, there are a lot more options out there diagnostically and medicine and with radiation. So the longer I can wait, hopefully forever, the less I have to think about plan B. But I wanted to make the comment, I would be foremost the person to think about an implant to fight this disease before I did any type of radiation or surgery. Thank you.
So
Thank you,
so
Gary.
Pam,
If I can make a comment here quickly, I mean, so when we started, everyone says, why hasn't this been done? This is such a simple idea. And the answer is because it's quite challenging to actually do this. Now, your comment with the glaucoma is a good one because I stole the entire team from people who did eye implants. So all the engineers are people who have done eye implants. So I have a team of 6 or 7 engineers and experts who have done exactly that because I wanted to deal with someone who knows how to do this. And but that's how it's not trivial to do it, and the engineering and the implants have to be just right. But I think once we can prove this principle, and I really like someone in the chat says, yeah, if I need it, we don't want to do this to someone who doesn't need it. We just want to have this should be a plan B. And once I think we created this proof of principle, then hopefully we can do this in other organs with other drugs.
Alexa, if you don't mind, I had a question for Pamela. Since you,
I want to check in on Martin real quick.
Hold on, Howard. Give someone else a shot. Somebody go ahead, Alexa.
Martin, did you have a comment you wanted to make?
No.
If not, that's okay.
No, he just left his mic on. Okay.
Oh, okay, that's fine. Howard, go ahead.
Yeah, Pamela, since you deal with both breast cancer and prostate cancer, I'd be interested in your perspective on this. There's a lot of things going on with the language of prostate cancer and certainly with breast cancer. And one of the things that I've noticed is a lot of women, it doesn't matter what degree of breast cancer they have, they like to call themselves survivors. And there's research that verifies that, at least from Australia. Men, on the other hand, don't like to be called survivors. And it doesn't matter, I mean, I think of the guys with low risk, and, we may have anxiety, but we really haven't gone through what the guys with advanced prostate cancer have gone through. And, but even the guys with advanced prostate cancer don't like to call themselves survivors. Do you have any insight on the survivor?
Yeah, and I know this is a recorded line, and I know that I'm gonna get a lot of flag for this. I do not like this name because my dear friend, who is the picture I showed first, says, so what about me? I didn't even manage to be a survivor. She had metastatic breast cancer and ultimately died. I think calling someone a survivor somewhat implies that someone with metastatic disease has failed this, when there's no fault of anyone having metastatic disease. So and just as much as there's, for people with BRCA mutation, they call us previvors before we have cancer, but that would actually imply that at some point I will have another cancer, and I'm not actually keen on that. So and while I do feel it is admirable that someone goes through breast cancer treatment or cancer treatment, I think this is great. But whether this turns out well or doesn't turn out well, that's often not in our hands. And And then that's what I really struggle with the term survivor, but that's my
I
personal.
appreciate it because you, so what do you call yourself? So I don't like thriver either. It sounds too peppy.
Honestly, Howard, lucky and privileged and grateful.
Sounds good to me.
And trying to be mindful that every day should be a good day, and and at the same time, I'm not mad at myself if I have a really bad day and I'm upset about this. It's like I think the one thing I learned in dealing with this from a physician side and from being on the patient side is like being kind to myself has probably made the biggest difference to my life.
Wow.
Going through the dealing with this, just not beating myself up for all the things I could be or should be or society expects me to be. I try to do good and I try to be kind to myself.
Sounds like a plan. I'm going to put
Ian,
Yeah.
you got a point to make. You go.
Okay, so this is what confounds me about this whole business. So I had a genomic test. My chances of survival in the next 10 years are 95%. So where am I going with that? And I know 10 years from now, the new normal is going to look so completely different based on what happened the last 10 years. I mean, just a few examples. PSMA PET scans are new. They've just come out. A lot of these therapies that are considered experimental will be mainstream, and Dr. Munster's approach might also be mainstream. So why am I rushing to treatment when things are going to look so much better just a few years from now? And that's what confounds me about the whole business.
Well, part of the strategy of active surveillance is to defer treatment.
Right.
And I know, and we know, guys who went on active surveillance, say 14 or 17 years ago, and things progressed. And but the thing is the technology changed in the intervening years, and they benefited from it, either new diagnostics or new treatment. So yeah, you make a good point, but it kind of depends on your state of mind and what your doctor is recommending, I think.
Well, I'm new in this process of getting second opinion. So
I have a
I'm
very
sure Rick
poignant,
has something to say.
yeah, I have a very poignant comment on that, on the Ian's point. I mean, I'm getting a lump in my throat. A lot of some of the guys who helped us start AnCan often said, and I'm thinking in particular of dear Dominic Moresi and others, that the strategy when you had metastatic prostate cancer and your time was short was that you just hung on for as long as you could, because sometime in that period there'd be something new that would come across and give you a little bit more time. And in a certain sense, that's exactly what Ian is saying, except he's moved it back in the disease path to a much earlier point. And I think that in any disease where treatment does not assure you of cure, which is very much true for any prostate cancer that is beyond 3+3, you're always going to be waiting for the next thing to create what is a cure. I mean, our view is, AnCan's view is that if a doctor tells you they're going to cure your prostate cancer and you've got a 4 in your number in your Gleason score, you've got to challenge them, because we don't have any evidence that they can do that. They can give you a durable remission, which thank God I have. As most of you know, I was a T3 4+4, and it seems like it's nailed it. But I got to get my PSA tested, and it could come back positive. And if it does come back positive, there's so many more things now. So I really feel strongly that this is so much what medicine is about. Take what's there right now and cross your fingers that something new is going to come along to help you pretty soon. Pamela, I've got a question for you. Is there anything you'd like to ask the guys that they can answer the way we've been doing it? Have we missed something that you would like a response on from them whilst we've still got a bunch of them here?
Yeah, so another question I have is like, and this really comes up, you know, as you can imagine, as a healthcare provider, we are completely baffled what happened during COVID, right? So, and I'm not even gonna go there, but there's so much information there, and social media, you know, this unfiltered medical opinions, facts, factoids, what have you. How do you get your information? Who do you pick as your doctor? How, you know, who's your guide? How do you select the captain of your ship?
So if you have something you'd like to share, feel free to turn your camera on, or if you don't want to share with your camera on, you can share in the chat as well. But go ahead, we want to hear what you have to say.
Come on, guys, who's going to be first? How do you select what doctor to go to? How do you select the best treatment?
Especially in active surveillance.
Well, you know, we do some discussion here on our personal experiences with individual doctors. We have featured a lot of the prominent doctors in active surveillance at our meetings. So, and we refer people to those videos, you know, if it fits with their geography. We stress the importance of second opinions. And so Dr. Epstein at Johns Hopkins has been doing a land office business, I guess, because we refer a lot to him. So there's a lot of synergy in this group and in other groups. So I don't know, that's my answer. Gary, how about
and then
you?
Robert?
I have a question, Steve Amaker.
A question or an answer to this question?
No, I just have a question.
Okay, well, hold on to that question. Let's get this question answered first, and we'll come to you, Steve. Robert?
Robert's next.
Yeah, go ahead, Robert.
Okay, so I've been seeing urologists over the years. Had a whole-up procedure done, different urologists. I really think it's a process of elimination. You get what you can get from one urologist or a series of tests, and then like we're sharing all this information, you gather this information and try to make some better decisions based on the information and discussions. So I would say that if you find someone that you think you like, it's great, but you have to keep your eyes and ears open because everybody is unique, it's individual. We're at different stages. And you have to monitor yourself at those stages and then seek out the person who you think might be able to help you and advance your thinking as you get older. So I'm in the process through these webinars and through Howard and another fellow that introduced me, I sent my slides to Jonathan Epstein, FedExed them overnight, got the results back yesterday in 2 days. So those slides are being sent to MD Anderson Cancer Center. I'm going to be seeing a new urologist because I want to get established there. Whether I stay with him or not is really a decision I'll have to make later. And I had a biopsy in November of 2020. I don't know if he's going to think that's too old. So if he wants to do another one, it'll be the Trans-Perennial, which is what I had before, an MRI guided. So we're up to that level now, which is good. So I just have to wait and see where this goes. It's going to be in April 4th. And then I'll have to determine what I'm going to do at that point on, whatever that urologist says. And
so it sounds like, in your opinion, it's just being your own best advocate of the way that in your process, you've done it.
Well, yeah, I think so. I mean, if you rely on doctors, I mean, The ones that I had before, the piranhas, the first thing I want to do is radiate. The second thing I want to do is surgery. And I'm a 3+3 and a level 1.
Thank you for sharing, Robert. We appreciate that.
that's-
Ira.
The organization I belong to, the Prostate Forum of Orange County, we've been doing in-person meetings, when people, to just, sharing meetings and presentations. But during this COVID, we switched over to, internet where we do Zoom. And we've been making alliances with other groups such as this, like, Joe Gallo and Howard Walensky. They're both, we share information about, this group, and they hopefully share information about our group. So, we're doing that. And as far as myself on a personal level, I did skip, I was supposed to see, my doctor every 6 months, but, I skipped, but then I saw him, and then I guess it was last March, and then he's, because I'm on it so long, he says, well, I don't think I should see you so often anymore, and I don't want to do too much for you anymore, because I think you don't have, whatever. So, but anyway, I'm seeing him again now, so it's more infrequent now, the meetings. So, and then that also applies to my regular doctor and all those other people.
Thank you. Thank you for
Yeah.
sharing. Dawn, did you have a comment?
I do. To answer the question directly, Dr. Munster, there is not a good course. You cannot rely on the doctors. You cannot rely on the surgeon. You can't rely on the radiation guys or gals. There is no clear path in any way, shape, or form for a newly diagnosed chump in this field to go get some legitimate input. Without AnCan, without my group here in Boulder, I would be SOL. That's shit out of luck. We would really be in deep doo-doo, and I would have been already radiated or surged, and I knew enough to go get an MRI before I had the first biopsy. Both of the doctors fought me going at a 4 PSA from 3.9. In my opinion, it's criminal, and there should be some piece of legislation set up so that the doctors have to inform you, as Howard is a proponent, to let you know of the potential. If you don't, fortunately I did my homework, of the potential for sepsis with a trust biopsy. It makes me very angry for the guys that are as yet to date undiagnosed, that are fixing to get diagnosed, and the unknowing lack of knowledge to seek a transperineal. In the greater Denver area, it's a very slim chance of getting a transperineal biopsy.
Thank you for sharing that, Dawn. That was so honest. I really appreciate it. Party Monster, do you have something to say?
Yes, I do. Thank you for asking. So the question I'm answering is, how do you find the right doctor? Am I correct? Because that's what I was interested in answering.
Yeah, go ahead, please. Like, I'm very curious about that.
Yeah, so here's the deal with me. Now, first of all, I went through 4 doctors, and there, for a variety of reasons, I did not really dig them. And thanks to Howard, I finally found a ride to see this guy at the University of Chicago, Dr. Eggener. And the way I define a good doctor is the guy a cool dude in a loose mood? And the way I define that is, like, it's all about vibe. I mean, if the guy has a good vibe and he's chill and he likes the same kind of music as I do, as he confirmed, he asked me what kind of music I like. And I said, everything from punk to Miles Davis. And he said, me too. That's the kind of guy I want to work with. I don't want some guy who's uptight or a robot or freaking out due to the pandemic. I want a dude like that. And I think I found somebody like that. So that's my answer. Thanks for listening.
No, really, I really appreciate these answers because, you know, having been on the patient side, you actually really learn what it takes to, what you hear. And we built the BRCA Center for Research at UCSF in part because I found it just incredibly difficult for me as a healthcare provider and oncologist at UCSF to find my care. It was really challenging. And you know, I always feel in a patient-doctor relationship, particularly in a relationship like yours, that's a long-term relationship. Why would you go to someone who you don't like? That just seems horrible. How are you gonna trust someone who you don't even like or doesn't like your music? I think this is important. So thank you for sharing that.
You're welcome.
And then Hugh, did you want to share something about this?
Sure. So I thought I had an okay urologist. I was diagnosed. I seemed to be fine with him. I joined the AnCan group and find out that well, he kind of did things as what we say back home, ass backwards. I mean, I had a biopsy and then I had an MRI, only to find out through this group, well, that's backwards. You should have an MRI and then a biopsy. And then also listening to this group, there were several guys that would come on and talk about going to centers of excellence, and several of them mentioned that they would talk with MD Anderson, and well, if they lived there, they would be a part of it. And I thought, well, that's pretty ridiculous. I live 3 miles from the place, so I should go over there and see if I can get in. And then several local guys here that I knew had prostate cancer and were at MD Anderson. So I went for a consultation and was extremely impressed because they, you know, before I even saw the doctor, boom, 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 he had all these tests lined up before he even sat down to talk about what we might do. So that was my experience to move over to MD Anderson.
Thank you. That's great. And Gary, did you have a comment about this?
Yeah, I would just like to comment that I think in life, whenever you have a problem, it could be with plumbing in your house, your car doesn't start, or anything like that, you always want to know somebody that knows a guy, because it's always good to know a guy. Because if you know a guy, you have more faith, you have more trust, and you feel more comfortable. Well, AnCan knows everybody. They know a guy. When you have a problem with this support group, I've said it before, the information is priceless. You cannot get this information anywhere else because you have a bunch of people that have either experienced or are experiencing the same difficulties. I went to my urologist and said, I want a transperineal, and he just said, well, I don't do that. And he didn't really, he said, well, maybe Moffitt in Tampa does it. I happen to be in Florida. Within 7 days, talking to Howard and Joe and other people in this group, I had an appointment at the Mayo Clinic in Jacksonville doing a precision point transperineal biopsy, all lined up, they turned me to everybody, and everybody actually contacted me. The gentleman that created Precision Point gave me the heads up on who he really liked. He happened to be at the Mayo. So I guess my point is, education is key. And if people have more, just a better way to get information in this group, as I said, they know a guy. I don't care where you live in this country, or basically in different parts of the world, from what I can understand so far. People in this group are more than willing and will bend over backwards to help you out, to get you what they think. It's always going to be up to you. You know a guy, but whether you use him or not is up to you. But the advice and the people that we've come to know are some best in the business, just like Jonathan Epstein. He's the best in the business. And we get people, you know, these guys have managed to get him to talk to patients on the way home. Who does that? He's the best in the country. Who does that? Who gets on their cell phone from work to home to discuss an individual they never met, his results, and maybe give him advice as to where he should go? Who does that? But we know a guy. And I think everybody needs to just, you know, you have to like who you're dealing with, but you have to, you know, you just have to take all the information. And as Alexa said, you have to be your own advocate. You have to keep asking questions. You can't just take one person's advice, but collectively, AnCan has a whole lot of advice and a whole lot of education, and they can cut the steps down into baby steps instead of miles. That was my comment. Thank you.
Gary, I have been a part of AnCan for I don't know how long at this point, and that was one of the most beautiful endorsements. That AnCan sounds pretty great. So I guess Gary is very pro peer support. We love that.
Well, Gary, how can we find this group you've been talking about? Now, Pamela.
I just wanted to take a pause there, and I think, Howard, you got the same thing. I just want to see how Pamela's doing. You know, we're willing to hang here longer as much as
she's already agreed to stay. She's agreed to stay, at least for me. And
I'm happy. You know, this is incredibly valuable for me. It's like as you know, it's incredibly valuable for me. This is a different world. I mean, I can't be doing prostate cancer treatment, not understand how the patients feel about this. This is, you know, I can listen to you guys all night. So.
Well, I think eventually you'll fall asleep, but you know, in our point of view in here may be different, and Joe could comment on that, and Rick can. That, you know, our point of view in here may be different than in the more advanced groups. So you should probably talk to them as well, and then let us know, and we'll see who's doing a better job, us or them. Not that we're competitive. But
so I'm going to share something with Pamela and invite her to a meeting that we're going to have. I think it's in June, when another member of our advisory board that we absolutely love, Dr. Eleni Evstathiou, has asked if she can come on to talk to our advanced guys. She's a GU medical oncologist, and she wants to come on to the advanced group to ask them what it is they want when they go to an appointment. What can she do to make the appointment better for them? What are their expectations? And when we have that meeting, Pamela, you are so welcome to join in and listen to what the guys say. And these will all be advanced guys who are all or should all be seeing a GU med onc.
I think there's some intermediate guys that want to hear that too, Rick.
They can come too.
Okay.
Eleni will be happy. No, as I know her, she'll be thrilled the more people that are there.
No, she's super. She's super.
Yeah.
Now, Pamela, you know, is there, maybe the guys can share some advice to you about, I think we've shared some already, but, you know, maybe the guys want to make some other point about, you know, how you should deal with guys like us.
Yeah, so if you allow me to just ask a couple of specific questions. We have this implant, right? And so I feel very strongly we need to have a transperineal approach, not a transrectal approach. It seems like from what I'm hearing, that's not going to cause a big problem. And then what I hear from urologists is that being in a stirrup for 45 minutes is going to be a problem if you're awake. Could you comment on that? Because the transperineal approach is often done in stirrups.
Joe Gallo, you kick this one off, man, and then we'll get a few more. I know.
I was just going to say, having been there, you know, if you have a good crew working with you, when you're in the stirrups, it's not a big deal. They can help make you very comfortable. And I would say that it was probably a little bit less comfortable than being on your side for a transrectal. but the overall process was quite fine, and we did it in a procedure room. So I highly recommend it.
Okay.
Hi, Gare.
Okay, well, I had a transperineal biopsy done at the Mayo Clinic, and I was under general anesthesia. Of course, it was the best nap ever. And when I woke up, everything was all good. So do I think I could have done it in the procedure room because I had a transrectal done in the procedure room, two of them, you know, and every time they pull the trigger, you know, you kind of know what they're doing. Did I survive it? Did I, you know, was it any really big problem? No, but of course, I don't have any underlying medical conditions. Perhaps for certain people, that would be a problem. I didn't have a concern about going under, which some people get really anxious about, I guess, because it is really, I guess, scary. They're kind of like killing you and bringing you back. But I had the best nap ever. It was all good. So 2 thumbs up for general anesthesia from my point. Go ahead, you. Go ahead, bud.
Well, I'm on the Gary. It's the Hugh and the Gary show that talks about anesthesia. So, yeah, I'm one. I've always had my biopsies with general anesthesia. Didn't know that you could have it another way. I'm a proponent for, you know, modern medicine, and why not be comfortable. But also, I think that just like you're sitting there saying, somebody's in the stirrups for a period of time of 45 minutes. It seems to me that the person who is doing that procedure is thinking about the comfort of the patient when they should be be thinking only of the procedure. So I'm a proponent, you know, of anesthesia, and you as the person who's doing the procedure, take your time and you don't have to worry about my comfort.
Well, point counterpoint.
Yeah.
I'm going to tell you that it was not a problem. The only discomfort that I had was the injection of lidocaine, which only lasted for a couple of seconds, and the rest of the time I was quite comfortable through the entire procedure, and I didn't feel the traditional snaps that you get from the transrectal.
He forgot to say that he's an ex-Marine.
Yeah,
that's what he forgot to tell us.
He's a bigger
Dr.
man
Munster,
than me.
Joe is an ex-Marine. You have to know that.
Well, and Gary's a former grunt, and I was a draft dodger.
You know, I don't know, Rick, you probably told us Max joined the Marines as an officer.
Yes. Yeah. I don't think I shared it with, I don't think I shared that with Joe. I should have done. But Joe, you'd be proud of Max. And guys, I'm not sure if Alexa did this, but we had a session last year or the year before, last year, I think, on inherited mutations, which we called the talk. We did one for prostate cancer too, where we had 2 family members talking about their condition, and Pamela and her son Max were incredibly gracious to join us and to talk very openly about the issues around Max having inherited the BRCA mutation from Pamela, who in turn had inherited it from her dad. So Alexa's just put it in there, and go on, watch that, and watch the presentation. And it's very moving. It's pretty amazing, and I was very thrilled from Pamela to hear that this is. I would never have guessed that that's what Max would choose just from listening to him, but pretty amazing. Were you surprised, Pamela?
Yeah. So Max always wanted to be a fighter pilot, and then he always wanted to go to the Air Force, and then he found out he's colorblind, and then decided to join the Marines because yeah.
Good for him.
Wow. So who else wants to talk about being up in the stirrups?
Yeah, I do.
Okay, go ahead, Ian.
Okay, so I might not be as tough as Joe, but I did have a transperennial biopsy, local anesthesia, took a little bit of Xanax first just to kind of take the edge off. It was not painful. I talked to the staff the whole way through, and wasn't a bad experience. And I want to answer a previous question also about how do you find the right doctor. The first one was the only guy I could drive to who did transperineal biopsy, so that was a no-brainer. I also look on Yelp and Google reviews, and this guy, when you see, had very good ratings from people who had seen him. I found those sites to be useful. And then when Rick put me on to a guy in Vegas. I haven't seen him yet, but I also went to Google reviews, and his reviews are off the charts. He looks great. So that can be useful too. So support group, word of mouth, but also get online and look at reviews.
Thank you.
And if you like stirrups, by the way, micro ultrasound is done that way as well.
Okay. No worries.
And by the way, you know, we like to make fun about the fact that Gary and Hugh prefer getting knocked out. But it's all in good fun, and I basically would support, I'm sort of pro-choice on this. I think the guy's got to decide which way to go. Don't get it confused with anything else, but pro-choice on whether to have it with anesthesia or without. But, you know, there, at any rate, it's all I
That's an
got.
important comment, actually, because I think right now the trial in Australia is with general anesthesia, because we were not quite clear how easy it would be to do this, but we know that the quick urologist can do it in about 40 minutes, and so maybe having a choice would be really helpful.
Meanwhile, it would be great if men had a greater ability to vote with their feet and their prostates and choose the way that they go. Too many communities don't have the choice.
Pamela, is transperineal perineal being offered at UCSF? Do you know?
Yeah, but yeah, I think for some reason, so when we did the trial in Australia and New Zealand, we said like, well, could you do transperineal rather than rectal? They said like, no one does rectal here. We don't believe in this. And so and then Europe is a bit different either, but it is coming, and clearly all the radiation therapists, they're very comfortable with this. So I'm not sure why people are so reluctant, because going through the rectum and sticking it to a clean space just doesn't seem such a great idea.
I have a cousin at one of the major centers. She's a urologist, and she's pretty typical. She says, I don't have a problem with sepsis, but she can't remember the last time she actually looked at her numbers. And because I tried to recruit her onto the transperineal side. And, you know, why do the doctors do this? Well, a lot of it's efficiency and workflow. You can bang out a lot more of these procedures if you do it transrectally. But, you know, to me, well, I posted in there an article I wrote over the weekend on the attack again. And I got sort of a nasty gram from somebody that was in the ASPE group, a physician, who says, well, why not wait for, you know, clinical trials, you know, a double-blind study? Well, and he pointed me to one. And so this study concludes in 2015. And so what are the guys supposed to do between now and then? And is it going to be definitive? If you need to make a choice, you need to make it now. So I wrote him a nasty gram back. But at any rate. So Pamela, anything else for this rowdy crowd?
No, I think any advice, unsolicited or solicited, or anything that you could think I could do, anything that's not out there that you really like to see, the nice thing about doing UCSF research is I can pretty much do what I want as long as I bring in my money and convince someone it's worthwhile supporting. Anything that you guys need that's not there that you want?
So Pamela, could I ask you one question? To come back to the comparison of the active surveillance with breast cancer. So, and you said, so where I'm coming from is my wife was diagnosed with breast cancer. And so when I attended these different meetings with her, I was surprised how quickly it was, yeah, surgery, get it out. And but then, so I understand, and I do understand the plumbing and the side effect issues are totally different. But how about for radiation? Why such a movement so quickly then for radiation when you have good imaging? So I can see take it out, image, and then maybe hold off on radiation.
So I think it's actually a very complex question, and the question for that goes to like in a lot of this, why would you ever do a one-sided mastectomy, right? There's no reason to do that actually. So the principle of breast cancers are that there's about 1 to 2% of women, and it's more in younger women, who have BRCA, ATM, or check mutation. Their risk for breast cancer is close to 80% over life. So they will get breast cancer very likely by the time they are 70. So that's a hugely high risk of getting breast cancer. And the breast cancer can come in any of the breasts. Now, if you just have one area of breast cancer and you're an older woman, taking this out and there's no other area at the breast that's at risk, there's actually no reason to have radiation. But because we don't bother testing who's really at risk, we just radiate everybody, and I think that's part of the problem. So this is lack of knowledge, and this is really an important part. There's an enormous amount of research being spent on it's like who's really at risk. Like in someone like me with a 80% chance of having breast cancer and 50% having chance of having second breast cancer after I had the first one, doing active surveillance probably is not a great thing. I already had one breast cancer, so the chance of having a second one was so high. So doing active surveillance in me with a BRCA mutation and the potential of having a nasty triple negative breast cancer that leads to death in 3 years, that was not worth I mean, I couldn't live with that risk.
Sure,
if I had, so that's the difference.
Yeah, but there's an awful lot of women that are on the other side that have very low risk, stage 0. You remove it, and it strikes me that not knowing enough about it, but that won't stop me from commenting. That again, it's one of those things where the medical community has thrown so much at the breast cancer. So as soon as you have breast cancer, just let's throw everything and get as many things as we can without doing enough research that sits there and says, well, we're overdoing it.
Totally.
So I'm going to jump in only because this is an interesting conversation, and I will be delighted to connect you with Pamela. And I know that you will be able to dialogue, but we're sort of leaving even our core area here, and people are dropping off.
Duly noted.
Alexa had to leave because she's taking lung meds right now, and she had to go get her lung meds. And so I think it's probably as good as any time.
Duly noted, Rick, and thank you for putting me back in my box.
No, it's fine. But I will tell you, Pamela, that we recently have provided peer support to 2 women with breast cancer, one of whom was Hugh's wife, and another was the sister of one of our advanced guys. And even though we don't have a group, we did it by pulling in peers, and Hugh's wife was wonderful in providing peer support to our other lady. So we're moving around the peripherals of.
Do you think Pamela might be interested in being the medical advisor to a group that you might start?
Oh, we'll talk about that. We've been trying to get an inherited mutations group started for the longest time, and it'll happen. And we've talked about that. But I feel so much for especially the kids of people that have inherited mutations, because the kids just don't know where to go next. And we talk about anxiety. These kids live with prostate, with cancer of multiple sorts hanging over their heads. So we'll go. But Pamela, I think I said to you.
Hang on, Rick. So
yes.
I actually got funding and support and a team to start a support group for young people, because I feel like these young people need to have someone to talk to. It's like, I mean, the question that they threw at Max is like, when you tell a date that you have a cancer mutation, and these questions that none of us can answer, which I think is important. So if you want if you want me to get involved in starting a young women's men's group,
we absolutely do. This goes back to that panel that I heard you on with those young kids on that breast cancer movie, whatever it was called. You'll remember. I forget what it was called, but the pink and blue thing. But I'll be in touch with you on this very shortly. I just want
another T-shirt then.
You want what?
I want another T-shirt then.
Okay, we can take care of another T-shirt for you. Okay. Listen, I told you our guys would be vocal. Were they vocal enough?
I think there's more to hear. I think it is a difficult topic, and I'm really impressed that people speak up. And I learned a lot, and you are vocal. And I think I think we need to get the medical system in a better system, because it's not right that a guy can make money on how many prostatectomies he does and not tell anyone that you don't have to do it. I think this is not right, and there's too many of those people out there.
We agree. We agree, and we're delighted to have you. We're honored to have you, and we'll continue working with you. And I'm sure we can set up more feedback sessions for you, even with some of the other groups. Alexa, as I say, had to go, so I've sort of had to take on the closing responsibilities. Maybe
looks like Gary has a question.
Gary, what's on your mind?
Yeah, and tell us who this guy is. Who's your guy? You got to turn on your voice. It's a secret.
When I first went to my urologist, my PSA had gone from a 3.9 with my primary care guy, and he says, "Oh, it's time to go see a urologist." So he does this. He sees me, and his hospital had just gotten a new Da Vinci robotic system that he had got certified to use, which most probably is a 2-day course, I'm sure. And you get a certificate saying you can operate the machine, because I guess you play on something else. And this guy was just anxious to give me a radical prostatectomy without even informing me about any possible side effects, not telling me. And I wasn't educated at all. I didn't know. And of course the guys are going to laugh, but my basic idea was, I have born into this life with all my equipment, and I'm going out with all my equipment. So I've got my tonsils, I've got everything I was born with. They haven't taken anything yet. Appendix, tonsils, wisdom teeth, I got it all. So I'm in with my equipment. I want to go out with my equipment. And I think
Gary, you do know the right guys.
And it was all about, I think, one of the things that we're not looking at, and I think all of us know it under our breath, it is truly about money. The surgeon wants to operate, the radiologist wants to radiate, Everybody's got some skin in the game. And it's all about I'm not saying that the physicians don't care, but I think that's always a big part of the issue. Just like I think Big Pharma has a little bit to play.
Well, I don't want to go there.
I know we have some sponsors in Big Pharma, so that's all.
No. That's not absolutely not the reason. That's not the reason. But trust me, I don't want to go there right now, and we'll talk about it. But what I would like to do is, Pamela, please feel free to stay on. The moderators should feel free to stay on. But guys, we've been going for well over 2 hours. You all should pat yourselves on the back. Thank you so much for providing great feedback to Dr. Munster. And we'll have a regular support group meeting next week. Come on back and we'll handle it. Any support questions you have then, just like we always do. And thank you so much. So everyone the moderators stay on. Pamela,
And I'll start helping the people dismiss who choose not to log off.
Okay, you do that.
Pamela, keep in mind the audience. In